Hi, this is Doug Sesserman. I'm the CEO of American Associates Ben-Gurion University of the Negev. We represent Israel's most innovative and exciting university here in the United States, building awareness for the great work at the university and ultimately funds to support the students and faculty and research designed to develop Israel's southern region, the Negev Desert. Welcome to our Live from Israel webinar series. It's #Webinar Wednesdays. It's noon Eastern time in New York. I'm in my apartment, but behind me is the virtual office of our office in Manhattan. And we have wonderful guests from Ben-Gurion University at 7 p.m. in Israel. This is our third webinar on the coronavirus and Ben-Gurion University's incredible task force that was put together under the leadership of BGU President Danny Shamovitz and the Vice President for External Affairs and Resource Development, Jeff Kay. There are more than 100 scientists working on over 70 different projects that is really Israel's most leading multidisciplinary comprehensive research effort to combat the coronavirus. Today, we have 3 projects and 4 people that are our guests. And the way the webinar will work is I'll introduce each one of them. They will talk for about 10 minutes each. After they're done talking, I'll facilitate a discussion for you as the participants with the speakers. To ask a question, you just click on the Q&A function at the bottom of your Zoom. I'll be able to read the Q&A function and then address the questions to the appropriate people. So today we have some incredible guests. We have Dr. Hadar Ben-Yoav. He's the head of BGU's Nanobioelectronic Laboratory. And he's going to talk about a 5-minute home test for coronavirus that his team is developing. We have Dr. Jessica Couschard from BGU's Department of Industrial Engineering. She's going to talk about her breakthrough work with medical emergency drones, which I like to call robots to the rescue. And finally, we have Dr. Stav Shapiro and Professor Mark Clarefield, who will talk about their important work responding to the elderly, one of the most vulnerable populations to the coronavirus. So let's get started. So Dr. Hadar Ben-Yoav is the senior lecturer in BGU's Department of Biomedical Engineering and the head of, as I mentioned before, the university's Nanobioelectronic Laboratory. His lab focuses on the integration of biological materials such as DNA, proteins, and cells into micro and nanoelectronic devices. Hadar's team is studying how biology can be harnessed to develop the next generation of personalized health monitoring applications, such as electronic skin patches and implantable sensors that can continuously monitor health. Hadar completed his postdoc research at the Department of Electrical and Computer Engineering at the University of Maryland. He holds a BS in Physics and Biology and an MS in Biotechnology and a PhD in Electrical Engineering, all from Tel Aviv University. Welcome, Hadar. So before you tell us about your research, please just explain to the audience what exactly happens in a nanobioelectronic laboratory. Hadar.
Well, in one word, fun. So what we actually do, we're kind of a multidisciplinary team that we study how molecules interact with electronic devices. So I can share the screen, right? So this is the team, and it's and first I want to thank everyone in my team that is working on this exciting field. And what we do actually is developing this kind of nanorobots, nano devices that can continuously and rapidly measure different molecules and diagnose diseases. Could be directly in our body or externally or in different types of biological fluids such as saliva or urine. So we designed those kind of devices, nanodevices that will interact with the molecules and detect the disease. So what we do is kind of introduced by this kind of quote that I like. It's back on 1674 when the physician Thomas Wheeler described that the way that diabetes was diagnosed. And this is basically those physicians taste urine of patients in order to know if they're sweet enough and detect if the person is sick with diabetes or not. It's because of the sugar in the urine. So what we try, so he actually described it as wonderfully sweet as if it was imbued with honey or sugar. So that's what we are trying to do. We try to develop, to invent new devices that that present the way that our tongue recognizes different flavors. But instead of flavors, we test different diseases. And this is an example of one of our devices that we developed, and I can show it here with my hand. And this kind of a micro sensor that we fabricate and manufacture here at Ben-Gurion University. This is an example of how we can, in this project, we use this kind of sensor to detect the coronavirus itself in saliva of patients. And for that, we take this kind of microsensor and we coat it with high density of different types of probes, receptors that can attract and bind to the virus, and by binding to that, generates electrical current that we actually measure. So think about this kind of microsensor. It's like the stadium, the football stadium, and all the fans are kind of those different receptors. And whenever a virus comes, those fans attach. They are very specific to the virus itself, to the external molecules, protein that it has. And when they bind it, they generate electrical signal, a very small electrical signal that we can measure and recognize that there is indeed a virus here. And we can, and also even what are the concentration of these viruses. So this is a kind of the main essence of this technology that we are trying to develop here in my lab, together with two groups at the Tel Aviv University, Professor Shaham Diamond and Professor Adi Avni, and also together here in Soroka, together with Dr. Yonat, that Shemer Yavnei, that she actually deals with the patients, and she can test eventually this device with the saliva extracted or was donated by these patients that were diagnosed positive for coronavirus. So we're trying to address the main challenges of the coronavirus pandemic. And by that, we would like to transfer the test itself that is being done in the hospital and commercial laboratories directly in home. And that's mainly because that to prevent interactions between the healthcare providers or the tester and the patients, because we know that a lot of healthcare providers were in contact with patients and were diagnosed as potential with coronavirus and went to quarantine and were able to treat with the patients. But not only that, if you could have this kind of test that can measure or that can be in everyone's home. And people that has a potential exposure to coronavirus, they can actually measure, take the saliva swab, put it in a kind of a tube, then after 1 or 2 minutes, they can load it in a device, put it back, and wait for the results. And this kind of bonding duration that I showed you before, they actually happen very fast. And we can
Hadar, we're getting a question from the audience. This one's from Ellen Marcus. She's asking, how can the microsensor detect different versions of the coronavirus, like the current pandemic is with COVID-19, but can this tell the different strains from each other?
So that's a good question, thank you. And those hands that we modified the surface of the sensor, they're specific to different types of the coronavirus. And actually right now we are in the middle of purchasing these kind of receptors called antibodies that are specific to 2 different types of proteins that are specific to the different types of strains of the coronavirus. So this is the way that we can, by integrating those receptors that are specific to the different types of the virus, we can distinguish between different coronavirus types.
So is the idea here that you could actually go to a local pharmacy and like you could get a pregnancy test, you could get a coronavirus test or an antibody test and do it at home?
That's the idea. This kind of tests, you know, the electronic part, it's usually about $50. And usually those tests, their disposable tests usually takes about $1 or $2. And by that, we can, the patient can go to the pharmacy, take the test, buy the device, or even get it from the health insurance company, and measure it. But not only that, if we can connect it into the network, into the internet, we think about this kind of space mission control center that can monitor different people all over, for example, Israel or different country or in other countries, and see their levels if they are changing every day. And whenever a patient, you know, when you see that kind of increase with the amount of the virus the patient has, so then, you know, kind of alarm is blinking and says, okay, we need to intervene and treat with this kind of patient.
Thank you very much, Hadar. Do you have anything else to add right now, or we'll switch to the next presenter and come back to you?
I just want to wrap up the thing that we are very excited about this work. And again, thank you for the Ben-Gurion University that supporting this work. And we're looking forward to help eventually the society.
So thank you very much, Dr. Hadar Ben-Yoav. And I can see that there are other questions people want to ask, and we'll bring Hadar back at the end of the webinar and ask more questions. So our next presenter, Hadar, if you could stop the share screen. Thank you very much. Perfectly done. Our next presenter is Dr. Jessica Couschard. She's a lecturer in BGU's Department of Industrial Engineering and Management. She's a worldwide expert in the fields of human computer and human robot interaction. Jessica's research also explores the impact of autonomous vehicles and intelligent devices. In 2015, the Brown Institute for Media Innovation awarded Jessica a MAGIC grant for her work on interacting with drones. Dr. Cauchard pursued postdoctoral research at Stanford University in Palo Alto. She completed her undergraduate degree in her home country of France, and then went to the UK, where she earned her master's degree in advanced computer science at Sheffield University and her PhD at Bristol University. Jessica recently made Aliyah to Israel in 2017. Welcome, Jessica. You need to unmute your line.
Good morning. Can you hear me now?
Perfect.
Okay, great. So let me share my screen and then we can start. Great. So my research is on human-computer and human-robot interaction. So we've been interested in how technologies can support us in our daily life. And this is the work we have been conducting for a little while. I've been at BGU for about a year now, and we have a lab called the Magic Lab with about 15 students looking both at the technical and the human challenges of how we will interact with the technology in the future and how technologies can help us for diverse applications. We have a very strong research agenda on human-drone interaction. And to show you what are the current application of drones, we have things like delivery, and we have been promised, for example, to have things delivered within 30 minutes to our homes through drones. We now have grocery delivery, and this is actually something that is like this picture has been taken during the Corona crisis, where people could not leave their home, and so a drone could come and deliver some food to them. And this is actually an old project, but a quite old project, 2014, where people were looking at an emergency drone that could come to a person and help them just on the street. And so those are the ideas of the applications that drone can help us with. And part of my research has been looking at drones in search and rescue situations where a drone could go and look for a person. So here the drone has found a person, but how do they communicate? Because even if the drone is here to help, at the end of the day, it just encounters a person and they have to be able to have some discussion if the drone wants to help. And so here the person is able to gesture to the drone, and I'm going to show you a video in a minute to what this looks like. So here we have a different situation where a person is maybe injured and on the ground. And so this drone can come, can explain that it's here to help, and can even give supplies to this person. So I'm going to show you a video of the type of research that we've been doing in this framework of search and rescue. We have actually, like right now, another project with a firefighting agency of Israel. And so here you see this drone is finding a person, she's intrigued, she starts looking at it, there is an interface, the drone is asking a question, and she can, with very, very simple gestures, so no learning at all, having never seen a drone before, she's able to just interact with it with a simple gesture. And then we see the same drone actually finding a person who needs help. And here you have to realize there are a ton of challenges. I mean, the drone needs to be able to come to the person. The person doesn't know if the drone is being controlled by someone like a security team or if it's autonomous, because the drone could be entirely autonomous. And so it needs to communicate and give enough feedback so the person knows what is happening and can actually get help. So here, for example, it is delivering medical supplies, and now they can start having a conversation where the person will be able to say if they need help, if they need urgent help, where they're injured, etc., etc. So here she's answering some questions from the drone, again with a very simple interface to do that. And so this is what we've been working on for the last year or so. And as the Corona crisis came, we started thinking, how can the drone start supporting people during the crisis? And so as we went on, we started really thinking about this notion of medical drones. So beyond the work we had done in search and rescue. And there are two main axes where drones can help here. And this is not exhaustive, but those are like the two main directions that we can look at. And so one is telemedicine. So we can start putting sensors like cameras, like thermal cameras. We can identify the temperature of a person, and we're able to actually help people through the drone, via the drone. And so the drone has actually been used and sometimes misused in the Corona crisis to monitor populations, trying to monitor and inform, but some governments have been doing better than others. And there's been a lot of discussion whether that was the right way of using those drones. But if you think about it, we can put sensors on the drone, and the drone can become an extension of the medical personnel. What is amazing here is it means that populations that are more at risk in the pandemic and can't leave their house could have a drone come and support them. So instead of a medic coming and putting them in danger, they could have a drone helping. And this is the work that I'm doing right now with Dr. Shapira, that we'll talk in a minute, where we're looking at supporting especially medically vulnerable population or vulnerable population in general in terms of having drones coming and helping them. The other one is still in the medical supplies. There are two angles that we're looking at. One are the technical challenges. The drone is to be able to recognize the person, safely interact. So here you're seeing an image from a depth camera, which is looking at positioning the drone compared to the person and identifying what the person wants to do with the drone. So here you can see the hand gesture interacting with the drone. And the second part is actually the human challenge. If a drone comes knocking at your window, are you feeling comfortable enough to open the window? And we don't even have the right metrics and the right methods right now to even start doing this research. And so Dr. Shapira and I, as part of the coronavirus task force, we've been identifying the right questions to ask different populations to identify when they're going to be comfortable with a drone coming to them or not. And in what are the considerations, what are the design aspects that will make some population be more okay for the drone to come or not to come towards them. And so
Jessica, we're getting a question from one of our participants. This is an anonymous participant is asking, how does the drone know where to go? How does it know where the person is in a search and rescue environment?
So this is a very good question. So in a search and rescue environment, the same way as a search and rescue team would do, they identify an area, and then as part of the area, we started covering different areas for the flight. And then the drone starts being able to recognize people. So with the use of thermal cameras, we're able to identify, for example, people and animals. And then as we get closer, we're able to identify if there's a person, and then we can approach that person and start to see whether this is the person we're looking for or not.
Thank you very much. Jessica, can you stop your share screen?
Sure. Thank you very much.
Would you like to make any last closing comments before we move to the next speakers?
I think it's a very exciting area. We're starting to see almost a revolution in how people have been using drones. Our governments have been using drones as part of this crisis, but the research is such early stage that we still have to learn how will people accept having drones in human spaces, and we're at the very forefront of this research. Thank you.
Thank you very much. It's incredibly interesting and impressive. Okay, we have two more speakers. They're a team. They're gonna talk on the same subject. So we have Dr. Stav Shapira, who's a lecturer in BGU's School of Public Health. Her main research interests are disaster preparedness and the response of and interaction between individuals, local communities, and healthcare systems. She also researches vulnerable populations, including the elderly and people with disabilities, in particular when they're faced with emergency situations, and how the integration of new and existing technologies are used for the purpose of improving emergency management and mitigating adverse health and social impacts. Dr. Shapira's work during the coronavirus pandemic focuses on providing support to older people via online platforms such as Zoom and WhatsApp. Dr. Shapiro completed her PhD at Ben-Gurion University. She holds a bachelor's degree in physiotherapy from Tel Aviv University and a master's degree from Bar Ilan University. And with her today also is Professor Mark Clarefield. Mark is Ben-Gurion University's Sidney Hecht Professor Emeritus of Geriatrics. He was previously director of the Geriatric Department at Soroka University Medical Center across the street from Ben-Gurion University, as well as the chief of geriatrics for Israel's Ministry of Health. He is currently an advisor to Israel's government on the COVID-19 crisis and is the lead author of Israel's Geriatric Society clinical guidelines for the care of older persons during this pandemic. From 2009 to 2018, many of us know Professor Clarefield as he served as the director of BGU's incredible Medical School for International Health. Mark grew up and was educated in Toronto, receiving his MD from the University of Toronto. He was on the Faculty of Medicine at McGill University until 1992, when he made Aliyah to Israel. Welcome, Stav and Mark. Thank you.
Thank you. Okay, let me just share my screen. One second, sorry. Okay, so thanks again, Doug. I would like to present today an ongoing research project about short-term cognitive behavioral group interventions via Zoom. To be more specific, we try to assess here whether these short-term cognitive behavioral group interventions via Zoom are an effective way to reduce subjective distress and to enhance resilience among older persons living in the community. So before I tell you about this project, I have to say a few words about the initiation of this project. So in mid-March, BGU's president, Professor Chaimovich, like Doug mentioned, invited the entire BGU research community to participate in a forum in order to initiate an integrated effort in various aspects associated with the Corona crisis, or like it was called the BGU Corona Task Force. So I actually participated in this meeting via Zoom since I was self-quarantined after returning from a trip abroad. But our multidisciplinary team, and you can see here, it's Dr. Daphne Schwartz from the Department of Communication Studies, Professor Limor Daniel, also from the School of Public Health and from the Prepared Center for Emergency Response Research, Professor Mark Clarfield, which you will hear after me, from the Medical School of International Health, and Professor Orly Sarit from the head of the Department of Social Work. So this very special multidisciplinary team and this project were established in that meeting. We're also a part of the Prepared Center for Emergency Response Research at BGU. So you can see we have a lot of support, here in this project. So basically, what motivated us was to develop this intervention for older persons was the beginning of the government's campaign calling at-risk populations to stay home and to practice social distancing, even from family and close friends. We knew this will help keep people safe from COVID-19, but may cause other difficulties, such as increased loneliness and social exclusion, and that eventually this may also have adverse impacts of people's physical and mental health. So our vision was to provide them with a virtual alternative space, a place to interact with others, to share their hardships, their strengths, to get or to provide support to others, and also to learn techniques and skills that will foster resilience and enhance coping strategies with the pandemic, with the situation itself, but also with the measures taken against it. So we disseminated an participation ad in WhatsApp groups of retired persons in Beersheba and its surroundings. And we received a flood of applications. So I'm really happy to share with you that we're currently running a pilot of 8 online support groups. Each group has about 7 participants. They receive 7 online sessions of about an hour and a half. And we also included in this project students from the Department of Communication Studies to help the participants to improve their online communication skills and to connect through Zoom. And also students from the Department of Social Work that assist the group's moderators and provide individual support for the participants. So as you can see, the BGU students also have a major contribution here. Basically what they're doing is the participant learning all kinds of techniques and skills from the cognitive behavioral therapeutic world. For example, mindfulness meditations and guided effective imaginary. Let me just, okay. So as you can see in this slide, we were able to lower their distress levels by approximately 30% for each session, sorry. You can see here we use the measure called the subjective units of distress scale. You can see here on the left side the units of the scale, and you can see that even if participants entered the session quite with a high level of relatively high level of distress, we are able to get them out relatively calm. So it's a really nice result. You can see here only one measure. We also witnessed a significant increase in measures related to resilience and to perceptions of support. So we're very, very happy with the results, and we intend to offer participants who will graduate the program to become instructors for other applicants with low digital literacy. In that way, to make them more than just participants, to empower them as essential community members in times of crisis. Our future aim is to apply this framework to much broader populations. It can be relevant for older persons living in sheltered housing, for remote rural communities or people with a suppressed immune system in routine times as well. So what is really nice in this methodology, in this framework, is that it's really important during the current situation, but it can be very, very relevant and important during routine as well. So, yeah.
Thank you, Stav. This is just a quick note to the participants. If you have a question, use the Q&A function and type your question there. We have a few people raising their hands, but during these webinars, we use the Q&A function to ask the questions. Stav, you had a chart that I think is really amazing in terms of the anxiety scale. I'd seen something like this before. One thing that stands out for me is that older people tend to not be as anxious as the rest of society in general. Could you just comment on why that might be and how that relates to the pandemic, even though they're a vulnerable population?
I'm sorry, can you ask me again? Did you say that they tend to be not as anxious as less anxious compared to the? Well, the distress scale you saw here is not exactly shows anxiety. It shows distress, which are a little different constructs. But I have to say that at least in Israel, and Mark will probably can comment on that better than I am, but the levels of distress among older persons is relatively high, and we're talking about routine times, not on crisis times, and not on times when they cannot interact with their family and significant others. So this is a major issue that can raise distress, and this is basically the reason we initiated this project.
Thank you for that clarification. So Mark, you're up next. Mark Clarefield.
All right, unmute him. You can hear me all right?
Perfect.
Yeah. Thank you very much, and good morning and good afternoon to people around the world, and thank you for inviting me. I'm going to, Stav talked about, well, actually, my first impression, just, I know Stav well, but I don't know the other two researchers, but I think this is a terrific example of the young, brilliant resources that BGU has, and I can kind of think of putting the 3 projects together, that Jessica would have a drone that brings some kind of medication that Hadar would figure out, and using Stav, she would have some kind of mechanism of discussing this with the patient and calming everybody down. So I think it's a nice example of how we could even have more additive effects. But I think this is a great example of the brilliance of our university, that these young
Mark,
people.
while you're talking about that, actually, I wanted to bring this up later, but we could talk about it now. Because one of the things Ben-Gurion University is really known for is its multidisciplinary research.
Exactly.
And this is a classic case.
I agree with you.
Could you just explain to the audience kind of what that means and how that has shown up as it relates to the work on COVID?
It has to do with the, all universities, have collaboration within their borders and without their borders. But I think that Ben-Gurion has a special kind of warmth and ease and lack of boundaries that I've never seen, and I've worked at other universities, many other universities. It really is a place where it's very easy for a young person like Stav, who's probably younger than my daughter, and an old guy like me can get together and work from very different disciplines. I think that that's typical of universities in general, but specifically to BGU. But Stav presented a kind of a micro intervention that we're trying to use to help older people. I'll talk a bit about the macro work that I've been doing, although I'm part of Stav's research project, and it's a lot of fun for me because I'm also, given my age, I'm a bit technophobic. I mean, I manage, but it's really fun to work with young people, and she can help me figure out how to use Zoom. But in my macro work, I've worked recently with the Israel Geriatric Society, I think as I've mentioned, in trying to bring together a multidisciplinary group from across the country, although 3 of the people were from BGU, looking at triage, designing triage in the nightmare case that I think some of you in New York came close to seeing, and certainly colleagues in Italy and Spain that I was in touch with were living through a nightmare scenario of people pouring into the emergency rooms, filling up the beds, filling up the intensive care units. People were dying at home, in nursing homes, on the floors of the emergency room. When we saw this happening, we got a group together and we designed a kind of triage instrument in the situation, God forbid, where our hospitals would be overwhelmed, in trying to decide in a fair and transparent way who would get the next ICU bed. So I don't want to go into that in detail, but that's what we're working on. And I was gratified we're going to publish that, actually, it's going to come out this week in the Journal of the American Geriatric Society, so the major American geriatrics journal. That's the short term, what happens in triage. The medium term, I was consulted by the Ministry of Health on how to deal with the most vulnerable people in any society, which is elderly people in nursing homes. And all around the world, including Israel, 1/3 to 1/2 of the deaths from COVID-19 were residents of nursing homes. We saw this around the world and we got very anxious about how to prevent this from happening in Israel. And while it's true, in Israel, 1/3 of the deaths are from nursing homes, our numbers relative to other countries are so low relative to other places that we actually, we have very few people dying from COVID, which is a great miracle, and I think a testament to the work that the Ministry of Health and the hospital system did over the last couple of months. Really a miracle how we kept the numbers down. So in the short term, I was in touch with colleagues in the UK, United States, Britain, France, Switzerland, Canada, in finding best practices in the nursing homes and helping the Ministry of Health craft what would be best for Israel. That's the medium term. In the long term, we had a meeting today of the Ministry of a consultative body to the Ministry of Health, in which we looked at how to plan for the next wave. We think, we hope and pray we're over the first wave in Israel. And it may be that this virus disappears and we all just go home and a year from now, we just laugh and look back. That's unlikely. It's much more likely there'll be a second wave, like there was in 1918 and 19 with the flu. This is not the flu, but it's a virus. And that terrible pandemic, had 3 waves. 3 waves, each one worse than the one before. If that were to happen in Israel, and it could, we want to be ready for it. We want to learn from the lessons that we have taken from this disaster and be ready for the next wave so that we know what to do. And we have some ideas about what to do at the micro level, like Stav has presented to you, and also at the medium and the macro level. What kind of policies the ministry should take, how we should prepare older people, how we can reduce the sense of anxiety and distress that they had. For example, it was a good idea to tell everyone to stay home and tell older people who are at high risk to isolate. But it was foolish to tell them not to go out of their apartment and go for a walk outside. There was absolutely no danger as long as you kept a social distance. And I think we overreacted, as did many people. I understand why we did, and this isn't a criticism. This is looking back, a retrospective look. Everyone in retrospect's a genius, so I'm a genius too, and so are you, because we can look back. But we learned that while we have to keep people, and we will keep people home in a second wave if we have to, but we'll be much better at giving them advice as to how to look after themselves. We'll tell them, you can go downstairs, you can see your children in person. You don't have to Zoom your children. Go downstairs, keep 6 feet, 2 meters between, don't touch anybody, and you can chat for 2 hours. No harm will come of you. That's just one example of what we learned, and it seems like a no-brainer, but in the middle of the crisis, we were so overwhelmed by our fears that the crisis would overwhelm the healthcare system that we probably went a little too far. Now, it's better to go too far than not to go far enough. But I think that at the next time there's a wave, we'll be more nuanced. We'll do the same things, but I think we'll do them better. And I think that the research that you've heard tonight at the micro and the individual level will help us, and some of the macro work that I've done with the Ministry of Health, with colleagues from around the world and colleagues from Ben-Gurion, will help us with the second wave, where, if and when it comes.
Thank you very much, Mark.
Thank you. You're welcome.
I'm going to change my virtual background for a minute to one of my favorite spots on campus, which is our DNA bridge. So for those of you who haven't visited Israel in some time, and nobody is right now except the Israelis, when you do get back there, you have to go south and see the amazing campus of Ben-Gurion University in Beersheba. One of my favorite parts is this bridge behind me that connects the university over the high-speed train that's only an hour away from Tel Aviv with the Advanced Technology Park. We call it the DNA bridge because it looks like a double helix DNA strand, and it's where the research and DNA from the university can get translated into new companies and commercial devices, and we're hearing about some of those today. So I just wanted to show this background. We're now going to open it up to questions. Our timing is really terrific. I thank all the presenters for being concise. So we have about 20 minutes for questions and answers. If you're on the audience and you'd like to ask a question of any of the presenters, just click on your Q&A function, ask the question, and then I'll send it to the respective presenter. So let's start with Josef Flashner. I think this is for you, Hadar, but also could be related to Jessica, to your work. He's asking, can any of the electronic devices be able to help with contact tracing?
Thank you, Joseph, for the good question. When we think about those devices, they can actually, the bigger picture is that due to the low cost of those devices and the variability of doing different type of tests, or the modularity of the test, we can have those at home, even for people that are not patients or defined as patients, but also to healthy people. And whenever there is a potential contact, people can just do the test by themselves and see if there is any initial levels of a specific virus. But not only that, we can develop different types of tests. It's not only for the coronavirus, but for example, for the flu virus, influenza. And by that, you can have kind of a home test that can be done based on the current situation, current healthcare situation in your country.
We're getting a question, Stav, for you from Ronnie Strongen, our marketing officer, asking, can you just explain a little bit how you are a multidisciplinary participant also in Jessica's research?
So yeah, Jessica is the drone person. She is responsible for the human-drone interaction. I am more of a public health researcher. I study public health, and I specifically study vulnerable populations. So what we did here, our collaboration is based on investigating the human-drone interaction in a public health emergency in vulnerable populations, mainly older persons. We also focus on Bedouin citizens and ultra-Orthodox people that are all vulnerable in the specific scenario of the coronavirus, but also in general in the Israeli society. So this is basically the essence of our collaboration.
Thank you. So Jessica, I know you wanted to respond also to the contact tracing, and then maybe you could just give us a little insight into how you view other disciplines collaborating with your research.
Yeah, sure. So first of all, I'm just going to follow on what Stav just said. So we met on campus, and it was like really amazing. Right away, we realized there were so many interesting questions that we were looking at from completely different angles. Because what happened is they're supporting people through policy, through understanding what the country can do to help people in specific cases. And we're doing the same thing with technology. And so it was a really, really good fit from the beginning. And very quickly, we had a lot of ideas of projects we could do together. What was funny about the project that what we're working on now is that this is a project we actually submitted for internal funding on using drone for medical emergencies. And if I'm honest and I tell the whole story, actually someone told us on campus that felt like an artificial collaboration, and they couldn't see why you would use drone in medical purpose. And we were very upset. And then the corona crisis came, and people were like, oh, you have this great project. And we're like, yes, it's really important, and this needs to happen. And it was really interesting how, for a lot of people, drones were not an obvious technology. But as soon as the crisis happened, this was the only technology that could reach people that were out of reach. And so there was a lot of support that could happen, and a lot of people started using drones. And what we saw, and this is what I said earlier, and there was a lot of good use, but also some misuses of drones. And I think in a way, what we talked about in contact tracing is one of those borderline technologies where yes, technology can help. Yes, maybe I want to know if I was close to someone that could have put me at risk. But how much is this really going to help my health, and how much is this going to help the government policing how people are moving around, and what technology can we use and should we use in the future? And so we've seen, for example, in the US, some local governments using drones to look at people's temperature in the street, and people were not okay with it, and it had to stop. And that was a lot of money, like a lot of cost that was just wasted because people did not accept. In China, people accepted. And so there's a very strong cultural element to how people will accept technology, and what are the features, what is the right way of bringing in this technology. And so what we're going to do with Stav, and what we've been working on so far, is understanding how do we help these vulnerable populations that have not really been reached by the government and by the health system so far, or not well enough, because they're obviously suffering more than the others. And how can we use technology to bridge the gap? And so there's a lot of opportunities, but a lot of research needs to happen to make sure that it is done properly and ethically, and that everybody will be willing to accept. And this is very important points that we need to work on.
Thank you very much. So we're blowing up with questions. I'm going to try to get to more of them. The audience is finding this talk very interesting. So this, I think, is for you, Stav, or you, Mark. It's kind of a public health question. And the participant is asking about public transportation. And what do you think the future might look like in a post-COVID world for cities like in New York, where you have a lot of people trying to get to work or get around on buses and subways? Especially this had also impacts the elderly in particular, but I think the question is just in general, if you had to look into the future with a crystal ball, what do you think we're learning about the future of public transportation?
I think, Mark, this is for you.
Yeah,
No?
okay, no problem. It's a great question because no one knows the answer to that. There is no right answer, but let's sort of think of the issues that that might help to dilute the problem. So we've been talking for years, for other reasons, of changing work hours. So instead of having rush hour go from sort of 7 to 9, you could have it staged from 6 to 8, 7:30 to 9:30, and so on. So you could dilute the density of the people in public transport. The second thing you could do is do what the people in the Asian countries have done for years, which is wear effective. You have to wear an effective face mask whenever you go out. So that does help. People have to learn how to, and it's not easy, learn how to not touch things and then touch your nose. I mean, the way that viruses in general, and COVID in particular, are passed is very prosaic. So if you go into a subway and the number of people is not too much, and you touch something but you don't wipe your nose afterwards, you're unlikely, I'm not saying you can't get it, you're unlikely to get it. Clearly, the use of public transport is going to depend on us solving other problems like serology testing to see who's been affected and who's immune. Eventually, this virus will either die out or it will cause herd immunity. Herd immunity is when enough people, or we'll get a vaccine. If we get a vaccine that works like the polio vaccine, we'll look back at this webinar as ancient history and we'll laugh at it. If there is no vaccine, there'll be many more webinars like this. But until there's a vaccine, there are other things that we can do to reduce the amount of cross-infection and being infected. You know, if a lot of young people get infected and most people at any age, let's be optimistic for a minute. Most people at any age, even the elderly, who get infected by coronavirus, do very well. A small minority of them, which is larger among older persons or people with comorbidity, with underlying diseases, get quite sick with it. Most of the people taking the New York subway, if they got sick with it, would not be seriously ill. So we have to be both alert on one hand and not hysterical on the other. I don't think I answered the question because it's not really answerable, but those are some of the thoughts of how we can move forward using public transport and other problems like getting together in a post office. It's the same problem.
Thank you, Mark. You also mentioned the herd immunity factor. Could you just go back to that and explain what that means and how it relates to something like public transportation?
Sure. Herd immunity means that when a population, take 100 people, when say 60, or depending on the virus or the bug involved, when 60, 70, or 80% of people are either vaccinated or have been sick, the people who haven't been exposed will not be infected because the people around them are immune by dint of having been sick already and now immune or vaccinated. So I'll give you an example. The reason that measles vaccine, it's so essential that measles vaccine is given to more than 95% of children If you give it to 90% of children, the 10% of children who are not immune, because the bug measles virus is so infectious, they'll get it. There are other viruses that are not so infectious, and you can have 60% of the population immune by dint of vaccination or being infected previously, and the 40% of people who are not exposed are unlikely to get it. So we think, we don't know, that herd immunity for this virus is maybe something like between 60 and 80%. It's not 50%, and it's not like the measles, which is almost, you need to vaccinate or have everyone be infected before the few of those who aren't infected are at risk. Stav, would you agree with that assessment? Okay. I like younger people to check that I haven't sort of forgotten my basic stuff. So there you go. I got a good mark.
Did you want to comment? And then I've got a question for Hadar.
No, I think Mark was very, very thorough.
Okay, great. So Hadar, this is for you. This question coming, a couple of questions in this area, but this is coming from Connie Katz and also Philip Gompertz. People want to know, when is your technology going to be available in the public, for the public? What's it going to take for this to become commercially available?
So that's always a good question. Right now, we're actually in the beginning of this project. We applied for a couple of national funding agencies. So we are working on funding this project. We have visibility tests that for detecting very small portions of these parts of the virus. In terms of timeline, we expect to have in the next half a year a prototype that can now be used in Soroka Hospital and any other hospital to test, to show how good our device is able to measure those, how it's good with the interaction with the patients. And I believe that in about 1 year, we'll be able to go to the next step of trying to get all the certificates, the ethical certificates, and the such as from the FDA or CE. So basically, it won't be for this year, but maybe if I'm not saying that it's going to be an outbreak for next year.
Okay, thank you for your honesty also. So our audience should understand this is a pioneering research effort. This product will not be commercially available in pharmacies or drugstores anytime soon. At the best, maybe a year from now. Okay, and if people are interested in the audience in funding particular projects or learning more about investment opportunities in new companies, we're happy to facilitate those conversations as well. This is a question for you, Jessica, and then we're going to try to begin wrapping up. A few people have asked about drones as they're flying around. How do they know how to navigate terrain, such as a forested area or electrical poles, etc.?
So this is a great question. It's actually really interesting because those are very often solved problems right now. Like the drone technology is doing really, really well. So in terms of positioning itself to the ground, like most drones, like I would say all of the drones on the market have sensors that enable them to position into the ground. A lot of drones that are coming out on the market now have detection collision, so they're actually able to move around, look at trees and avoid any collision course. So these are actually, we're pretty well in that sense. What is harder is to start communicating and working with people. Like when you get close to a person, you can avoid a collision, but if you want to communicate, then there's a lot of parameters that need to be taken into consideration. And that is the very early stage. But then the navigation itself, we have incredible algorithms that work really well for that. We can't hear you, Doug.
We're getting a build question from Suzanne Bull that related to what you're saying, Jessica. She's asking about, do you have the facilities you need for, I've heard you talk about a a drone cage. You know, do you have what you need to take your research to the next level, or if you
it's
people
work in
had
progress.
$1 million, what would you do with it?
Well, I would invest it in my drone cage. So we have several facilities on campus. So we have a fabrication space that actually just finished building the first week of confinement. So I've not seen it yet. I've seen the pictures, but I have not been able to see it yet. And so we can build our own drones now on campus, which is really special. And we're in the process of building a drone cage, but this has been a lengthy process, and we hope that because of the crisis and the government budget cuts, this is not going to affect the lab. So if people are willing to invest, then we can definitely use this to make like facilities that would help us do this research. So one of the things we're trying to do in this cage is, for example, to recreate a human environment. So we could recreate a home, or we could recreate a home and a window, and then we could test different ways for the drone to approach, to get there, for people to communicate with it, and make sure that we can create this technology that would be safe and acceptable for people to use.
Excellent. Okay, so our time is wrapping up, but at the discretion of the moderator, we'll go a couple of minutes because our audience is still holding on strongly. I just want to give Stav, Mark, Hadar, Jessica, give you each a moment to say any final words if you'd like. Hadar?
Yeah, thank you, Doug. And I guess thank you everyone for the excellent questions. And I guess always time is too short to answer everything. So I'm happy to answer in private. But eventually the work is based on the very intelligent students we have here in Ben-Gurion University, the ability to absorb different types of fields, physics, chemistry, biology, medical sciences. And that's why I think BGU, we were able to achieve this kind of project here. Thank you.
Stav, maybe you're next. And we actually just got another question about how are we going to keep the older population safe and when they get back to shopping or going to synagogue, etc.
Okay, so first of all, I have to say, I'm not a physician. Mark is, but I'm not a physician. I study most of the time the social aspects of emergency situations or healthcare in general, not medicine. So maybe it's a good question for Mark. But what I would like to comment, just a few words to wrap it up, is that Hadar is investigating the coronavirus itself, but our study focuses on the aspects related to the measures taken against the pandemic and the social impacts it has on the population, on vulnerable populations in specific. And I think this is something that most people tend to, not to forget, but it's not on the focus. So I think it's a really important issue in this kind of scenario. And I hope, I hope our results will be able to bring some important information to this field.
Thank you. Mark, any closing comments?
Yeah, I want to close with some bad news and good news. The bad news is that this is not a very nice virus. The good news is that most people get through it quite well. Older persons are going to have to be patient. This pandemic, like all pandemics, goes up, it goes down, it can bounce a little bit. It won't be with us. It's not the plague. It's not smallpox. It's not going to be with us. It's unlikely to be with us in a virulent form. Unlikely. I hope I don't eat my words. For another 10 years. But it could take a year or two before things have stabilized in the sense of herd immunity or a vaccine or medication. So people who are at high risk, which is anyone over age 60, and the older, the more high risk you are, anyone with comorbidity, you're at higher risk. It doesn't mean you have to lock yourself up at home. It means you have to be careful. and you have to be patient. We'll get through this. The whole world, this is the first time that the whole world has concentrated on one little virus. That's never happened before. And so as bad as it is, including BGU and many other universities around the world, there's a tremendous amount of work concentrated on the whole world. And that's why I'm optimistic in the end that we'll get through this, but it will take a little time and people have to be patient and not push their governments to do things too quickly and too recklessly.
We're actually getting, Mark, a final question related to that, just on PTSD. Do we have any measures on the kind of longer term effect and how that breaks out by segments of society?
I doubt very much whether we're going to see much PTSD from this virus, because if you don't get sick with it, you're not post-trauma. It'll be interesting to see what happens to those people who go to the intensive care unit, live through it. This disease takes a while to, if you survive it, and I said most people do, but if you require intensive care therapy and ventilation, you can be ill for a number of months. Whether it's PTSD or the physical sequelae, which we don't understand yet. But this virus, when you're sick with it, and again, it doesn't happen with everybody, affects many organs. So we're going to have a small, a low percentage, but a large number of absolute people who survived it and have been sick, and it remains to be seen. But I think most people who recover from it will get through it all right, but that's just a guess.
Doug, can I add 2 words about the PTSD issue?
Please.
Okay, so PTSD scales usually refer to a single event, a traumatic event. The coronavirus is a continuous event. So we have the same problem, by the way, in Israel with our Gaza-Israel situation. Okay, it's a continuous event. So the existing scales of that to measure to diagnose PTSD are not a good fit to diagnose PTSD. So it's a very good question without a very good answer.
I agree.
Yeah, I know here people are very worried about the medical, the healthcare workers, the long-term effects on their psychology, but even just people are worried about when businesses start to open, how's it safe? Am I okay to get on the subway and go to work? If I'm single, how do I date somebody? So the truth is we're in such an uncertain environment, we don't know its long-term effects. Jessica, do you have any final words?
You're muted again.
Do you have any final words, Jessica?
Yes, actually, I can tell you there's been some people doing drone dating in New York, so that's a good news. You can use a drone to send like little messages to people, so that has been happening. This is a new usage, a new application of drones. I think what's really interesting is what we've seen in this crisis is that all of us are affected by it all over the world, and it's very new in some way that something is affecting everybody together at the same time. That said, we're not all equal in the crisis, and developing nations will suffer probably a lot longer than we will in Israel or in the States or in Canada, for example. This is going to be a very long-term problem for them, and it's good. Like, it's a shift. It's a shift in how we are living. We're not living the same way in how we communicate with each other, with our family, this time we spend together, the decision we make, like when I go to the supermarket, I have to get my mask and my gloves, and I have to wash my, I have to watch out for what is happening. Is somebody like tapping on my shoulder? Is this okay? It's changing us as people in how we communicate to each other. And it's also changing how technology can help us. But it also means that we need to design technology to support us and not necessarily just to police us. And here we have opportunities to make the world better tomorrow, but we have to be careful and really use this opportunity to make it better and not to make it worse. And this is, I think, what we're doing at BGU this year.
That was perfect.
Amen.
Okay, so I want to thank our presenters, Dr. Hadar Ben-Yoav, Dr. Jessica Couschard, Dr. Stav Shapira, and Professor Mark Clarefield for a very interesting discussion. Stav, did you want to say something?
No.
Okay, great.
Thank you.
And then I'm going to share my screen for a second. For those of you who are interested, let me just see if I can get this so that you can see it. Perfect, hopefully. For those of you who are interested in seeking more information, or if you'd like to donate to these research efforts, you can go to our website, aabgu.org/BGU-COVID-19 for all kinds of terrific information on the various research projects. And if you would like to donate to support these efforts, you can do so there as well at aabgu.org/donate-COVID-19. We have some other webinars coming up. I'm going to try to share screen again. Let's see, hold on. Hopefully you can see this. Terrific. Okay, so this is actually my computer, and I've just gone to our website, aabgu.org. It's a great resource for all kinds of information on how to get more involved. There's an event section about different things upcoming. Our next webinar is on, actually today is May 13th. Our next webinar is on May 27th. This Sunday we have an open house and virtual Board of Governors meeting that is open to the public if people would like to participate. That will be this Sunday at 11 a.m. Eastern. And our next webinar on COVID will focus on frontline workers, some of our alumni doctors, especially from the school, Medical School for International Health, about their experience on COVID. So again, I just want to thank everybody for participating. I especially want to thank the staff behind the scenes, Melody Mokhtarian, Dana Ben-Benyamin, and Ronnie Strongen for all their work for putting this together, and the speakers. And I just want to close with a comment from David Ben-Gurion, who was a visionary. I call him the #2 Jew all time. He saw the future of Israel and the future of the world in the Negev. And I think he also saw maybe the coronavirus coming. He at one point said, "The courage is knowing how to fear what ought to be feared and how not to fear what ought not to be feared." And I just want to thank all of our panelists, because as you're learning more about how to deal with the coronavirus, I think we can all feel a lot better, have less anxiety, and not be as fearful. So thank you to the great work at Ben-Gurion University. It's our pleasure to represent you here in the United States. Be safe, everyone. Stay healthy. Thank you.
Bye-bye. All the best.
Bye, stay safe.